Good afternoon, everyone. Thank you for joining us today. Today, I'll be speaking to you about a topic that I spent the last year researching, genetic carrier screening in gamete donation. And given the increasing popularity of assisted reproduction and the quick implementation of new technologies into this space, I think today's topic introduces quite a timely conversation about conducting assisted reproduction in an accessible and ethically appropriate manner. Before we get started, though, I'd like to acknowledge that today I'm attending from the lands of the Gadigal people of the Eora Nation. I'd like to pay my respects to elders past, present, and emerging, and extend that respect to any Aboriginal people present here today. I'd also like to thank you, Molly, for giving me the opportunity to speak today, and to my wonderful supervisors, Giselle Newton, Julia Mansour, and Lisa Dive, for all their support and insight, throughout this entire research journey. I also quickly just wanted to mention that I've been working on this topic as part of my master's thesis, and I'm hoping to submit it for publication soon. So if anyone has any feedback today, I would really appreciate that. All right, let's get started. So I've got an overview of the presentation structure here. I'll start by introducing some of the background and the main concepts around genetic carrier screening, and talk about the evolution of that space, particularly because I know we have quite a diverse audience here today. Then I'll just talk about our methods and results. And while I'm going through the results, I'll highlight some of the ethical, clinical, and social challenges and the research gaps that we identified. And then I'll just close off the more formal portion of today with a quick summary and a discussion of some future directions. And hopefully that sets us up for an interesting discussion for the rest of this session. So let's start at the top. What is genetic carrier screening? Genetic carrier screening is a screening method that is aimed at individuals or couples without a significant personal or family history of genetic disease. As indicated by its name, its goal is to identify carriers who are healthy individuals who may pass on genetic changes and have children with a genetic condition. So if you look at the two pictures I've got on the slide here, both sets of parents here are healthy individuals, and they typically be unaffected with any signs or symptoms of a genetic condition themselves. But they can still go on to have children that are affected with what we call a recessive genetic condition. And a recessive condition just means that to have the condition, you need to have no working copies of a gene. There are two types of recessive conditions, autosomal and X-linked recessive. With an autosomal recessive condition, humans typically inherit 2 copies of that gene, and one comes from each parent. And to have the condition, both of those copies need to be non-functional. And with X-linked recessive conditions, they typically affect males because for certain genes, they only inherit 1 copy of the gene, and they would have that condition if that copy was non-functional. And then I've just got some interesting facts here that provide hopefully a little bit of context. At the moment, we know of approximately 2,000 recessive conditions. But it's expected that in the future, as we learn about more of those rare and ultra rare conditions, that this number can go up to 10,000. And even with our current level of knowledge, about 90% of people that are identified as carriers by genetic carrier screening have absolutely no family history of a genetic condition. So the only way that they would learn that they were carriers is if they had a child with a recessive condition, and then they would find out this information after the fact. So hopefully you now have a little bit of context on genetic carrier screening. Now I'll just talk you through the evolution of that space. So the history of genetic carrier screening is quite interesting, or at least I think it's quite interesting. It was introduced in the reproductive space in the 1970s, and that's actually years before the first gene was ever sequenced. And it was originally conducted through these different biochemical methods. And I've just got an example up here. The other thing is that it was conducted through these community screening programs. And the reason for that was that carrier screening was originally developed to look for very specific conditions that were frequent in certain ethnic groups. Yeah, the picture here is an example of a community screening program for sickle cell anemia, which is a condition where your red blood cells would change into these rigid sickle-shaped structures. And, they can block your blood vessels and cause these really painful episodes from quite a young age. And, it is quite a severe condition, and quite frequent in, or not quite frequent, but more frequent in people of African descent. So in the past, as I mentioned, they would have these screening programs, and the idea was to work out if people were carriers so they could make informed reproductive choices. And that is the general ethos of genetic carrier screening up to today. I did want to highlight one point here. Originally, and for a long time from this point, screening was only available for single conditions, or in very rare conditions for a handful of conditions. And it was offered based on this ethnicity-based model of risk. Even in the 1980s, when genetic testing became possible, they continued to follow this ethnicity-based model. And that was because of technological and financial constraints. Now, in leading up to the early 2000s, there were a few changes in social dynamics that made this a little bit difficult. So there was an increase in migration and mingling between people of different ethnicities. And it was soon realized that it was becoming quite difficult to assign people to a single ethnicity. And in doing so, they were actually missing out on many, many carriers. So in 2001, cystic fibrosis was the first condition for which screening was made available to everyone, regardless of which ethnic group they belong to. But again, I want to point out that this is a single condition. And those same restrictions with, the technological financial barriers still held true. This changed in 2010. So the new technologies had dramatically increased the amount of genetic information that could be analyzed at a reasonable cost. And this allowed for the development of a new panel-based screen called expanded carrier screening. And if you have a look here, expanded carrier screening can look at multiple conditions simultaneously. And just for a point of reference, some of you might be aware of the recent Embase item number for 3-gene screening. Expanded carrier screening is basically that, but on steroids. Like the 3-gene screen, expanded carrier screening can be offered to individuals or couples without having to consider their ethnicity. And as our knowledge of genetics is increasing, we're realizing that it's really important to be able to offer this, without these barriers of ethnicity, because practically everyone is a carrier for at least 2 lethal conditions. And on average, 1 to 2% of all couples have an increased risk of having a child with a recessive condition. And so unsurprisingly, this has led to a trend where an increased number of people are being considered for genetic carrier screening, and particularly expanded carrier screening. And I've got a little graph here that illustrates that. So if you have a look here, the market share of expanded carrier screening is already quite a bit higher than targeted disease screening or ethnicity-based screening. But if you look at the prediction for the next 20 years, that number just amplifies by a huge amount. And so clearly, both genetic carrier screening and expanded carrier screening are gaining popularity in a large amount of reproductive settings. And we'll focus on, one setting among them, which is sperm and egg donation, which we will collectively call gamete donation from now on. And, third-party service providers, so, IVF clinics and gamete banks have been using genetic carrier screening for a very long time as part of the medical screening for gamete donors. But recently, there have been two important changes to this landscape. More and more third-party service providers are making expanded carrier screening a mandatory requirement for gamete donors. And the size of expanded carrier screening panels is increasing. And, the question comes to mind, why does that matter? It's because we know from other genetic testing and screening scenarios that this can create new ethical, social, and clinical challenges. So our research really started at this point. We asked the question, what is the impact of this? And the literature on this space is fairly limited. So we had to be a little bit creative with how we went about answering this question. So we realized that there are quite a few different stakeholders in gamete donation, and they all interact with genetic carrier screening in different ways. And so we worked out that they could all provide different lenses to explore this question. And then we could kind of compare and contrast to kind of work out something about the landscape as a whole. So I'll quickly just introduce you to our stakeholders. Gamete donors, as you can imagine, are the individuals that provide eggs or sperm for gamete donation. Then you have the gamete recipients who use these gametes to achieve pregnancy. Hopefully that pregnancy grows into a healthy, happy, donor-conceived individual. And because their health is, intricately linked to the donors, the level of screening has implications for them. Then you've got third-party service providers who I've already mentioned, they're involved in recruiting and screening donors. So of course, the guidelines around screening would have implications for them. And then, of course, you have healthcare professionals, and I put them in this overarching way because they interact with all our other stakeholders. They provide information and support recipients with reproductive decision-making. They provide information to donor-conceived individuals about their genetic risks, and possibly the same to donors, depending on how that system functions. And, we'd imagine that they either oversee or participate in the work of third-party service providers in all the functions that they perform. So as you can see, there's quite a few dependencies in this system, and that provided an interesting structure for us to answer our research question. So I'll talk you through our methods now. So our research aim was to understand the impact of genetic carrier screening on gamete donation, using the experiences and perspectives of different stakeholders as a lens to explore the topic. We used a scoping review with narrative synthesis, and we searched for databases, Medline, Embase, CINAHL, and Scopus. We included articles that looked at the experiences, the perspectives, the post-testing experiences, and psychological outcomes of all stakeholders involved in gamete donation. And in the end, we ended up with 25 papers that fit our criteria. and then used, data extraction and narrative synthesis to generate new insights from the existing literature. And one of the very first things that we noticed is that although expanded carrier screening is becoming more common, it looks very different between different countries and different labs. It looks different in the number and types of conditions that are screened for. The results can be interpreted or communicated in different ways depending on, who's looking at them. And one of the main reasons for this is that there is a lack of clear standardized guidelines. And to sort of illustrate this point, I've just put up a picture of the guidelines for from America. And, points 1 and 2, oh, where's my cursor? Over here, just talk about, screening that should be offered to everyone. And then point C over here says that expanded carrier screening may be offered if it's appropriate. And then sort of the paragraph goes on to detail that, expanded carrier screening can look different depending on the panel and the lab that you're using. And, I've sort of gone through these guidelines, and at no point does it describe what as appropriate means. And even through my very preliminary Google searching, I've noticed that, there are different labs that are sort of interpreting this as expanded carrier screening should be offered to everyone, and that is the standard. Whereas other places are seeing it as, offer the more common conditions, and then everyone will have to pay for expanded carrier screening. So the ambiguity in these guidelines is, influencing, the level of screening that is offered across different practices. And then we sort of looked for, I guess, themes in our results that answered the question of what the impact was of genetic carrier screening. And we worked out that there were these four different, basically these four different themes that we identified. The first was that genetic carrier screening influences a donor's willingness to donate. It influences for recipients how they make their reproductive choices and plans. It influences donor eligibility and the need for genetic knowledge and skills in gamete donation. And I'll talk to these points in the broader context of gamete donation. So the first theme, as I said, is about donors' willingness to donate. And the first question, I guess, that came to mind for me was, why? Why would genetic carrier screening influence, this aspect for donors? And that answer is on here. Genetic carrier screening introduces new benefits and harms for donors. So as you can imagine, genetic information can be useful for a donor's health, and, they can pass on that information to their family, and it could potentially be of use to them. However, the same information can also be harmful. And the thing to, I guess, understand here is that the potential harms from genetic tests are often psychosocial rather than physical. And genetic carrier screening, the results, if they're not explained properly, can be a source of anxiety, can create a negative self-image, and can introduce all of this uncertainty into a donor's life. It can also introduce potential for discrimination against carriers in, certain cultural societies. And this can impact decision-making related to reproduction, insurance, and even, general lifestyle. The last point that I've got here is we mentioned that, genetic information that, we find out for donors could be beneficial to their families. But now they might have that responsibility of communicating these results to their family. And that depending on the family system, may not always be an easy thing. And expanded carrier screening only amplifies these benefits and harms. Of course, with expanded carrier screening, we are looking at so many more conditions. And so, there's always the potential to find, more information. The problem with that is often these genes may not be very well researched. And so the information that we find could have a lot of uncertainty inherent in there. And, if you tell a donor, hey, I found, this information, it might or might not have some very severe implications for your health, that could be quite terrifying and quite anxiety provoking. So I guess we know that, it impacts donors' willingness to donate. Let's sort of explore, what's happening there. So over the past 20-something years, there have only been 2 studies that looked into the experiences of donors with genetic carrier screening. In both those studies, donors expressed that they were willing to have the testing and have the results shared with recipients. But when it came to, finding out that information themselves, they were a little bit more hesitant. And that was particularly because they were worried about the long-term psychological impact of some of that information. And then when they were asked about, participating in future screening, and the assumption here is that, future screening will be more broad, looking at more genes and more conditions. They were also a little bit uncertain about, whether they would be comfortable participating in that in the future. And, the implication of that is that donors that, decline genetic carrier screening, they may not be able to participate in gamete donation at all. And, what does that mean for accessibility of gamete donation as a whole? And, I just wanted to put that, I guess, in the broader context a little bit. Countries that primarily using altruistic donation, they're already having a lot of challenges with recruiting donors. And, how does the benefit of genetic carrier screening weigh up against the potential decrease in the size of the donor pool? And our next theme might, provide a little bit more insight into this. So theme 2 was related to donors' reproductive choices and plans. And one of the things that we noticed in our results was that while recipients claimed that genetic carrier screening results were one of the most important factors for them in donor selection, in actuality, there were all of these other factors that were influencing how they use the results and if they use the results at all. And I've got a few examples up there. Obviously, some of the most common ones would be if, there are no other substitute donor samples, then you would go ahead with it. The severity of the condition carried by the donor influenced, whether they use these results, their age, and the time between, so the other logistics around, when their insemination was planned, are a few of them. And really, I guess, when you think about this in terms of, the broader ethics of of gamete donation, it kind of highlights that there is this mismatch between this requirement and this mandate of genetic carrier screening that is placed on donors, and then the application of genetic carrier screening results by recipients. And there are 2, I guess, dimensions to this. The first one is, from an ethical perspective, we need to think about whether we are denying donors the freedom to decline genetic carrier screening. And, in I guess, being in genetics, I know that we advocate heavily for the right not to know. And that's something that we try to offer to pretty much everyone, because we understand that the psychological impact of genetic test results can be, burdensome. So, are we sort of pushing donors into this situation where, they're kind of either forced to agree and go through genetic carrier screening when they're not completely comfortable with it? Or are they just going to have to, back out of gamete donation? And what implications does that have for accessibility and clinical practice and, just, the societal impact of gamete donation? Continuing on, I guess, on recipients' experiences, they mentioned that genetic carrier screening was influencing accessibility from their perspective in a few other ways. So I just quickly pulled an example of expanded carrier screening from Australian clinical labs. And I've got here that the turnaround time for expanded carrier screening is between 7 to 9 weeks. And there is an additional cost associated with that that's not covered by Medicare. And that's pretty much what recipients talked about. They mentioned that there were unwanted delays in their reproductive plans because of long turnaround times for genetic carrier screening. And they mentioned that they were incurring these additional costs. And, it is curious because at the moment, there is a rise in this phenomenon called fertility tourism, which is basically a form of medical tourism, but with people going, overseas to look for different fertility treatments. And obviously the main conditions for that are long wait lists and, high costs. And, with genetic carrier screening sort of adding to these, we should think about, whether this is a contributing factor and is driving, more people overseas or to look for donors in other ways. Our third theme sort of continues on this topic of accessibility. So expanded carrier screening, genetic carrier screening, but particularly expanded carrier screening, can influence the number of eligible donors that are allowed to participate in gamete donation. So for a little bit of, just context, in the past, and even to this day, there are some countries and some labs that recommend that donors be rejected if they're found to be carriers. Now with expanded carrier screening and what I mentioned earlier about pretty much everyone being a carrier for something, how is that going to impact the size of the donor pool? And, with places that are sort of continuing on to follow this process of just rejecting donors, their donor size is just, the size of their donor pool is just getting smaller and smaller. Fortunately, there are some gamete banks that are sort of leading the charge in this space. And they are, developing new processes around that can sort of navigate around this issue. For example, some services are refining their criteria for donor eligibility. And some others are actually involving recipients more in donor selection. And then they're incorporating new resources like genetic counseling and risk assessments to support recipients. And the question of, donor eligibility really opens up this whole host of other ethical questions. And some of these, I think we are at a space to answer, and some of them we're definitely still quite far away from there. The first question here is it okay to use donors who are carriers? And I think with what we've just discussed, we can answer that one. and it probably is okay to use donors who are. The second question is, are third-party service providers obligated to inform recipients about essentially the donor's carrier status? And, while it is, I can't answer the question about obligation. What I can say is that they are preemptively informing recipients about those risks. And then, as we said, they're incorporating, different resources to educate recipients to not just reject a donor just because they are found to be a carrier of something. The other questions, whose responsibility is it if a child ends up developing a genetic condition? Should the recipients be tested too? And what happens if a recipient does not want to be tested? Those, I think, are questions to be answered by future research. And then our final theme relates to healthcare providers. So healthcare providers are, and actually I should say that when I say healthcare providers here, I mean fertility healthcare providers. So for example, like a reproductive endocrinologist was one of the groups that they looked at. So they are tasked with supporting donors and recipients with genetic carrier screening results and sort of interpreting and helping them understand the value of that information. But what we found through our research was that, healthcare providers often feel inexperienced and unskilled to take on this role. And they mentioned that, a lack of knowledge and challenges with interpretation and counseling were the main barriers that kept them from, even offering expanded carrier screening to their clients. Another main challenge that we've already sort of discussed is the absence of clear professional recommendations, and also a lack of limited expert direction in the space. Unsurprisingly, training in genetics is shown to be useful in some aspects of this process. And fortunately, in some countries, they are promoting genetics-focused CPD for healthcare providers. I did quickly want to talk about what the implications were for client care. So genetic carrier screening is most useful when it is accompanied by conversations around disability, the recipient's perspective on risk, and the strengths and limitations of genetic carrier screening. However, a lack of confidence can cause healthcare professionals to neglect a patient's psychosocial needs. And, this is a problem, particularly because patients see doctors as, some of their most important sources for psychosocial support. And, neglecting their needs can be damaging to the healthcare professional-patient relationship and negatively impact their outcomes. So after that very long monologue, I will quickly summarize. So integrating genetic carrier screening in gamete donation is obviously creating new ethical, legal, clinical, and social challenges for all stakeholders. And our results really highlight the tensions and contradictions between stakeholders regarding the purpose and application of genetic carrier screening. And, future research is definitely required in this space. Future research is required into the experiences of all stakeholders. And, you've probably not picked up on this, but we actually didn't talk about donor-conceived individuals and the staff at gamete banks because there is no research available for those two groups at this time. Most of the research that we talked about has been conducted in the US, almost 80% of it. And so we really need to do, research on this topic in other settings to gain a better understanding of, the impact of genetic carrier screening. And, of course, we've mentioned accessibility multiple times during this conversation. And so future research is required to sort of quantify the impact of genetic carrier screening on the accessibility of gamete donation. Finally, sort of ending on a bioethics note, research should attempt to explore what role genetic carrier screening should play in gamete donation.